We have a very full agenda with 4 short presentations and a very big panel of people who are here to answer your questions. So the first 2 presentations will provide a quick overview of a few different research projects that are happening in Kenya, India, Guatemala, Nepal, the Gambia, and Ethiopia. So the presenters will share briefly a mix of results and also upcoming work plans. We're then going to take a moment to do some poll questions to hear about your experiences with chlorination implementation and some of the challenges that you may be facing or may anticipate that you will face. And then the second 2 presentations, the second set, will shift the focus to discuss resources for tackling some of these chlorination challenges. The last half hour is a discussion session for Q&A, but we really want to encourage you not to wait until the discussion to start asking your questions and submitting comments as well. So please use the chat box to share your relevant experience and ask questions in the Q&A box. You can start to ask your questions during the presentations. The panel team will begin responding right away. We have a big panel team today. So we have presenters from UC Berkeley, EVAG Sandek, Self-Help Africa, which is SHA, COVA, and PATH. And we're also very fortunate to be joined by project partners and members of the global decentralized chlorination community of practice, a bit of a tongue twister, who are joining us as speakers from Kenya, Nepal, Ethiopia, and the Gambia. So a special welcome to Mary Sami, who's the lead water quality officer from Fundifix in Kenya, to Balmukunda Kunwar, research and development specialist from Helvetas, Nepal, and Mohammed Lahai, project officer at SHA in the Gambia. Thank you so much for joining us. We also have a few others. Daniel Abera, who's a senior researcher from the Ethiopian Public Health Institute, and Donato Patrici, co-founder of Clara Water AG, and Mwanzia Kioko, program officer from CARE Kenya, who are very busy and some in transit at the moment, but may join us a bit later on. So this crew represents a very rich set of experience, so please do take advantage of the time that they're spending with us today to ask all of your questions. So I just, before we dive into the main content, there are a few points that I would like to highlight. Firstly, the webinar has come together to investigate this possibility of sustained, consistent chlorinated water for all. Today, we only have an hour and a half. So of course, we won't be able to cover chlorinated water for all in all contexts under the sun. The presenters will focus on decentralized settings where water for communities, schools, and healthcare facilities is available from small water supplies. They're going to share work on treatment within water supply systems before points of collection. So we are not covering large water supply urban systems today, and we're not covering household water treatment technologies. The presenters will share examples of a range of chlorination technologies, including on-site chlorine generation and both liquid and tablet-based passive dosing devices. So in this context, passive means devices that don't require electricity, so they can function without a power supply. It doesn't mean that they don't need care for operation and maintenance and refills. So these are not things that you can just put in place and let them passively exist forever. Passive just refers to the power supply. So the presenters are going to focus on efforts to evaluate and improve the effectiveness and impact of chlorination. As with all things in WASH, this mission requires an understanding of water treatment as not just a narrow technical challenge, but rather something complex and systemic. So for those who joined the RWSN Demystifying System Strengthening webinar earlier this month, I think this view will be particularly fresh in your minds. There are many factors that combine to influence the effectiveness and sustainability of decentralized chlorination efforts. These relate to user acceptability, supply chains, operation and maintenance models, and many other issues. The presentations today won't have time to discuss all of these aspects in depth, but we will link in the chat to some research on this wider systemic view of the chlorination mission. So if you want to follow up on some of those studies, we will share them. But mostly I really want to encourage you to take a broad systemic view today in the questions that you ask. So please prompt us to discuss this wider system that chlorination is operating within. So we're going to move to the presentations now. In the interests of time, I will be doing very brief introductions to the presenters, but please do have a look at the webinar registration page to see short bios and a LinkedIn link for each speaker if you would like to follow up more with them or see more about what they're working on. Great, so your first two presenters are Yoshika Kreider and Jeremy Lowe. They are joining us from the Pickering Lab at UC Berkeley in the US. They're going to be giving you a preview of their upcoming work that they're going to be doing in Kenya next year. And also they will share results from an evaluation of inline chlorination in Odisha, India.
Hi, everyone. My name is Yoshika Kreider, and I'm a postdoctoral scholar at UC Berkeley and a member of the Pickering Lab. And our lab works on disrupting environmental pathogen transmission and expanding access to safe drinking water through inline chlorination. So today, along with my colleague, Jeremy Lowe, we're going to do 3 mini presentations on 3 different projects that we're working on in the Pickering Lab. The first one, Jeremy will describe the TerryTap, which is a novel liquid chlorine doser. The second presentation, I'll describe the CLEAN randomized control trial, which is our ongoing trial in Western Kenya in health facilities to reduce neonatal infections. And finally, I'll pass it back to Jeremy to talk about the results of an implementation trial of inline chlorination in India.
So just to discuss inline chlorination a bit more, I want to talk about like the different different paradigms of water treatment that are available to us. So on one end of the spectrum, we have point of use water treatment, and often these are household level products. And on the other end of the spectrum, we have centralized drinking water treatment and distribution. But inline chlorination fits in as a point of collection water treatment method. And these are targeting often community water points like central storage tanks or taps to provide chlorinated drinking water. And, water treatment really matters. And there's been a recent study that found that fecal contamination, particularly, is the primary factor limiting access to safely managed drinking water. And in fact, it affects almost half of the population in low and middle income countries. And we know that chlorination can be particularly effective when it comes to fecal contamination. And there are currently over an estimated 2 billion people that use drinking water sources right now that could be compatible with inline chlorination. And so I want to first start by talking about the TerryTap. And so the TerryTap is one of these passive inline chlorination technologies that is able to dose chlorine into drinking water at central community water points. And so it provides precise dosing at the point of water collection. Often this is central water taps or storage tanks. It's electricity independent. There's no moving parts. It has a low user burden, so there's no daily operation and maintenance needs. Refills are provided every few weeks to it. We estimate it has a low production cost at scale, and it's compatible with intermittent flow ranging from 6 to 60 liters per minute. And it's able to dose chlorine passively into water using what is known as the Venturi principle, which is just a fluid dynamics principle that is able to pull in chlorine into the main drinking water line. It also relies on liquid chlorine. And so we've been able to effectively pair this with electrochlorinators in the past for on-site generation of chlorine to be used in treatment. And this product has a long history as well. So we've previously demonstrated it has effective demand among private water kiosk owners in a study from 2019 in Kenya. And in the last few years, we've also been conducting long-term evaluation of tray tap prototypes in 4 healthcare facilities in Western Kenya. And this product has a long history and it's led us to today where we're scaling up. And so we're completing an initial production run of 200 units, and we hope for these to be available starting in 2025. Our distribution and sales partner, Davidson Shirtliff, also plans to begin selling tray taps across Africa in 2025 as well. And if you're interested in more updates, you can sign up using this QR code here, and we'll reach out. So now I'll pass it back to Yoshika to talk about the CLEAN trial.
Thanks, Jeremy. So the CLEAN trial stands for chlorination to reduce enteric and antibiotic-resistant infections in neonates. And so we know that one of the applications for passive chlorination technologies is in healthcare facilities to provide reliable, safe water supply for patients and staff. In these health facilities, interrupting the transmission of pathogens is a high priority to prevent hospital-acquired infections, especially antibiotic-resistant infections, which can be costly and difficult to treat. And one area of particular interest is maternity wards, where these infections contribute to high rates of maternal and neonatal morbidity and mortality. And so the CLEAN trial is a cluster randomized control trial in 40 public health facilities in rural Western Kenya, looking at the impact of passive chlorination paired with disinfectant supply to reduce these infections. And we have a multi-PI team, including UC Berkeley and researchers at the Kenya Medical Research Institute, as well as a number of other investigators at Berkeley and KEMRI. This trial is funded by the National Institute of Allergy and Infectious Diseases, Open Philanthropy, and the Global Innovation Fund. So as some motivation, our team conducted a survey of 60 public health facilities in Western Kenya, and we found that 97% have guidelines for infection prevention and control, or IPC precautions, disinfection and sterilization guidelines, and also staff training for those guidelines. But that 45% of these facilities reported shortages in disinfectant supply that made it difficult to follow these guidelines. And in our environmental sampling, more than 50% of water supplies or water samples were contaminated with E. coli, and long storage times, intermittent supply, and manual transport of water pose contamination risks in these facilities. So our conclusion from this preliminary work was that infrastructure and resource constraints make it hard to implement IPC guidelines effectively, but that this also provides an opportunity for adapting low-cost solutions such as passive chlorinators. And so our objective in this work is to evaluate a scalable multi-component chlorination intervention for health facilities to reduce the threat of antibiotic-resistant infections for mothers and their neonates. And our intervention consists of passive chlorination technologies for safe water, such as the Turi tap, paired with a reliable supply of chlorine disinfectant, which is randomized to be provided either using an electrochlorinator or through bulk delivery of liquid chlorine solution, with the idea that this disinfectant can be used for refilling the passive chlorination technologies, but also for surface disinfection needs in the facility. And we'll be measuring contamination of hands, water, and surfaces in these facilities. We'll also be collecting rectal swabs in a subset of mother neonate pairs to look at gut carriage of bacterial pathogens, including antibiotic-resistant pathogens that are associated with sepsis. And then we are also measuring clinical signs and symptoms of serious infection 7 days after birth among up to 62,000 mothers and neonates over the course of 2 years, and will be launching baseline data collection in January of 2025. So I'll pass it back to Jeremy to talk about some of the work from India.
Thanks, Yoshika. So, like Yoshika was mentioning in the Clean trial, that's focused on implementing inline chlorination in healthcare facilities. But now I want to talk about our implementation trial of inline chlorination in rural communities in India. And so, for context on India, we're coming into this project after the success of the Jal Jeevan mission, which is focused on providing a drinking water tap for every single rural Indian household by 2024. And often what this looks like is a large central concrete storage tank that feeds individual household tap connections, shown here in the photo. However, this water is supplied intermittently, is often untreated. And so this introduces concerns for microbiological contamination that we think inline chlorination can improve. So for this study, the objectives were to implement inline chlorination in 10 randomly selected villages and with having 10 villages serving as control in rural Odisha, India, and refining the installation and maintenance protocols. We also wanted to analyze the reductions in total coliform and E. coli following implementing inline chlorination, and also looking at reductions in antibiotic resistance as well. And lastly, we wanted to assess community uptake of chlorinated drinking water and any practices of multiple water source use. And I won't discuss the technologies too in detail, but just briefly, these are chlorine tablet-based inline chlorination technologies. The one on the left shown is the Purell 100, and the one on the right is the CTI-8. And how these technologies work is that you're able to attach a bypass line directly onto an existing distribution line. Water is then able to passively flow over a stack of chlorine tablets that passively dissolve and then inject water back into the main distribution line that is chlorinated. So for the results, so this figure here shows the proportion of taps in the villages that were positive for chlorine over the given study period over the last year. And I think what we found here is that we had variable dosing, or we had a variable proportion of taps that are positive for chlorine when we were targeting a low chlorine dose, closer to 0.2 milligrams per liter. But in September, after we changed our protocol and started dosing at a higher level, closer to 0.4 milligrams per liter, we saw that we were able to effectively chlorinate in almost 100% of the tap connections in the villages. And so consistent chlorine dosing really depends on providing refills on time, maintaining this adequate dose to account for any variable performance as chlorine tablets dissolve in the chlorinators, and also having operator compliance for operation. We also saw that inline chlorination could effectively reduce microbial contamination in household drinking water. And so this figure shows the percentage of samples that were positive for E. coli in household drinking water, both stored drinking water that was collected earlier that day and also tap drinking water. And the two colors show both the control group in red and the treatment group as well in blue. And lastly, we were also able to find that inline chlorination can mitigate the transmission of antibiotic resistance in drinking water. And so again, we were looking at antibiotic resistant E. coli in stored and tap drinking water in households. And again, we see that the treatment group has significantly a lower proportion of samples that were positive for antibiotic resistant E. coli. So with that, I'll close, and thank you so much for joining, and our contact information is here if you all want to reach out in the future. Thanks so much.
Wonderful. So big thanks to Yoshika and Jeremy for that presentation. We are going to move directly into the second presentation now, but please do put any other questions for the Kenya and India projects in the question and answer box. We already have some great questions coming through, so thank you. So your second set of presenters are Marissa Bohler and Loic Fache from EOVAG Sandek in Switzerland, and Mathieu Metois from SHA, and he's based in the UK. So they're going to be sharing some results and future plans for their ongoing collaborative work in Guatemala, Nepal, Ethiopia, and the Gambia. And some of the project partners, as I said before, are also with us and will be answering your questions. So please, please do take advantage of their time today and ask your questions. So we'll go to the presentation. Thank you.
Hello, everyone. So at this presentation, I'll try to give you an overview of the different projects we have here around chlorination at Sandbeck, EAVAG, where we do research on water sanitation and solid waste for development. So our projects around chlorination are mostly focusing on low-cost inline chlorination for drinking water disinfection. And as you can see on the map, we are working on several projects around the world. For example, in rural Guatemala, we have worked together with the local community to construct a passive inline chlorinator for 4 piped water supply systems. The systems operated with the inline chlorinator showed significant reductions of E. coli levels at the tap. However, only when the systems were properly and actively chlorinated, an almost complete reduction was observed. This shows how important consistent operation is. And you can also find more details here in this article that we recently published. Another area where we've evaluated inline chlorination is rural Nepal. We're now looking into assessing these operational efficiencies more in details, and we will be comparing different chlorination arrangements in piped water supplies. We'll be looking at 10 rural water supply schemes with different technologies and different degrees of decentralization. We'll evaluate the ease of operation maintenance, cost efficiency, treatment performance, and user satisfaction for schemes with centralized, semi-centralized, and decentralized chlorination, so that in the end we can assess trade-offs between these different methods and arrangements. And now over to Matthew from Self-Help Africa, with who we're also collaborating.
Thanks, Marissa. So, hello everybody. I'm Mathieu Métois, Global WASH Technical Officer for Self-Help Africa. We are currently working in 17 countries, but more specifically in Malawi, Nigeria, Gambia, we are strengthening capacities for professional maintenance services. And we have been working so far mostly on hand pump, but in Gambia, more specifically, we are looking also more and more to solar powered piped water schemes. In Gambia, more specifically, because the shift to this technology is happening quite rapidly. And despite the country is quite small, there is a lack of monitoring and lack of follow-up, lack of guidelines in terms of construction. And as a result, that a lot of those schemes are not functional. And it's quite difficult for remote rural communities to have access to companies, operators and also is quite expensive. So after a first study of a phase of study, sorry, you don't too quickly. So can you go back, please?
Yeah.
So yeah, we established this partnership with a local company, Gam Solar, who is proposing 5-year guarantee service to rural communities. This service includes quarterly visit for preventive maintenance, and we have a review with local institutions and users on the performances. And Gam Solar is recruiting also a local operator for the day-to-day management. And we are installing smart prepaid meters to facilitate the payment and also for online monitoring. Next slide, please. So yeah, the background of our collaboration with EWAG comes from the study that shows that a lot of water points are contaminated with Escherichia coli, 66% of the source, but also it rose to 92% of water at household level. So yeah, we started in 2022-23 a collaboration with EWAG, looking at different possible options either filters for household treatment, or improve container or improve transport containers. And we looked also at locally made inline chlorinators with a local plumber. And so, yeah, after this first phase, we decided to focus on this option of inline chlorinators. And within our pilot, we will start with 6 communities doing the rehabilitation and doing the upgrade by installing inline chlorinators. So yeah, we want to study if the local operator can manage properly, can supply the chlorine. Also check if the acceptance from users, especially with the test of chlorine. But most of all, yeah, between the arrangement with GAMP Solar, between the home connection, we want to study the benefits of moving from basic access to seawater to safely manage, especially with women being less obliged to cover a long distance to get water. We think that, yeah, the volume of water available could increase. We think also that the expenses in terms of health could decrease. And so, yeah, we will study those socio-economic and gender benefits. So we are at the early stage. We started a baseline in September. So yeah, we will be comparing between these 6 intervention communities and 6 control communities. So an end line is planned in almost a year. And in the meantime, we will do regular monitoring, control of the treatment, the water quality, and yeah, the follow-up of the capacities of GAMP Solar to intervene in time. And we will be doing also some focus group discussion. So this is it. And yeah, happy to discuss later on the results. Handing over to Loic now.
Yeah, thank you, Mathieu. So now I'm going to present the final project we have, which is the evaluation of inline chlorination using electrolysis in Ethiopia. It's a collaboration with the Ethiopian Public Health Institute and Clara, which is a startup based in Ethiopia. So I'm going to present in a bit more detail because we have more results on that study. The rationale is that, as you know, safe water is still an issue. In Ethiopia, half of the population lacks safe drinking water, and they have issues with reliable supply chains of chlorine, which is why producing it locally could be a good option. Our research questions are, we are looking at the reliability, operation, and maintenance of that inline chlorinator, of inline chlorination using electrolysis. We are looking at what's the water quality at the point of distribution and at the point of consumption, and what's the impact of the inline chlorination on child health, which is, so we are looking at diarrhea, fever, respiratory infections, and malnutrition. So the study design is quite similar to the one we have in Gambia. We had a baseline collection with a questionnaire to households, anthropometric measurements, and water quality tests. Then our partner Clara intervened and installed 3 chlorinators in the intervention sites. And then we had inline data collection in which we repeated the baseline 1 year after installation. So the study sites are situated in the south of Hawassa, in the south of Ethiopia. They are quite rural villages that lack access to basic facilities. The method, so we have a household questionnaire that comprises questions on and observation on wash knowledge, wash infrastructure, child health, and nutrition. We complement it with child health measurements, so weight, height or length, and MUAC, as well as 13 clinical signs of malnutrition, and water quality test at the point of distribution and consumption, which are E. coli and total coliform, which we test with membrane filtration, as well as chlorine and pH. So for the results, a third of the interviewees were illiterate, 74% of them were farmers. The water supply was mostly shared water supply, with 75% having access to piped water in the village and 15% to piped water to the household or the yard. 89% used the same container for transport and storage. They were almost always jerry cans, and only 15% were clean. Sanitation, hand washing, and hygiene was quite poor, with remarkably almost no hand washing facilities. pit latrines for 86% of the houses, and quite a number of animal feces in and outside the house. So for the water quality at the points of distribution, we have the baseline on the left. So the contamination was quite high already at the point of distribution at baseline, with only about 25 to 30% of the samples being free from E. coli. At the end line, we see a massive difference between intervention and control, with in the intervention site, more than 80% of the sample being free from E. coli at the point of distribution. At the point of consumption, there was even more E. coli at baseline, and you can also see a reduction at end line in the intervention sites. The control sites are quite similar at end line and baseline, which we see here better. So this is the change from baseline to end line, and we can see that there was more than a 50% increase of 0 E. coli sample at the point of distribution in the intervention zone. At the point of consumption, it was a 35% increase of 0 E. coli samples for the intervention. And for the control, the changes were less than 10% for each category. Now we are looking at a graph that's looking at the FRC and E. coli association. So we found that concentration that were higher than 1 milligram liter led to much more samples being at 0 E. coli. So the chlorination was really efficient, very efficient from 1 milligram per liter, which is higher than what the WHO recommends. For the child health, we have a significant difference between baseline and end line, but the analysis is still ongoing, so we are not going to present the full results now because we don't have them yet. We see a significant difference, but we are still determining what factors can explain this difference. Now for the challenges that we encountered during the intervention, the biggest one was intermittent supply that led to source switching. So the supply was not always constant. They were lacking fuel or diesel or electricity to pump the water from the groundwater, which led to the water not being pumped into the system and the households to switch sources. Also, there was issue with the payment of operators that were not always paid on time and then stopped working, which was also a factor of interruption of the chlorination this time and not of the whole system. So to conclude, the intervention improved the drinking water quality, both at point of distribution and consumption. We need to improve the reliability of operations. Intermittency was widespread and it triggered a lot of source switching. And since the other sources in the area are not clean, this led to non-consistent consumption of clean water. And there were still significant levels of recontamination at the point of consumption. The wash conditions are quite poor. They slightly improved during the project time, but not a lot. So yeah, that's it. And I'm happy to answer any of your questions.
Wonderful. Thank you so much to Marissa, Loic, and Mathieu for those presentations. Just a reminder to please put questions in the question and answer box and not in the chat box. I know it's easy to mix the two up, but it's a lot easier for the panelists to see the question and answer box questions. So we're less likely to miss your question if you put it there. So we are about to start a poll. The results shared in both presentations 1 and 2 really emphasized the importance of consistency in operating chlorinators. And the presenters highlighted some challenges with doing refills on time to maintain sufficient dosing, with figuring out what is a sufficient dose, and issues with the reliance on power to pump water, even though the chlorinator itself may be a passive device. The power supply is still really important for the water supply. So with some of these challenges in mind, we then would like to ask a bit more about some of your experiences and to hear what challenges are most front of mind for you. So the first question is what is your current role, just to help us get a sense of who is on the webinar today. So please respond. Your options are researcher or academic, water supply professional, community development worker, NGO representative, student or educator, government official, or an interested individual who doesn't feel like you're a fit to any of those other categories. And do suggest if you would like other categories that we could provide in future polls if you don't like these options. Okay, so then the second question is, what is your experience with decentralized passive chlorination? And the options we have provided are maybe you're working on doing routine implementation, doing trial implementation, you're learning about options, you're doing research or evaluation of implementation, you are providing guidance for implementation, you have no experience yet, and this is something you're interested in. Or if other, then please specify in the chat what else you would like to respond. And this is a multiple choice question, so you can select multiple responses if you would like. Great, and then the third and final question, if you just scroll down in the poll box that has hopefully popped up for you on your screen. If you scroll down, you will find the third question, which is, what are the most difficult challenges that hinder consistent chlorination? So here we have tried to populate this with some options of common challenges. So maybe related to supply chain is the first option. And then we ask you to check the box for what you feel is the most true in your specific experience. So is this a challenge that is mostly manageable? So something you have a fairly good handle on and not particularly concerned about. An issue that is somewhat challenging would be something that's maybe not your main obstacle or priority, but it is something that you're facing. And then very challenging is for things that you find very difficult to overcome. There's maybe no clear path forward, and you would consider this a priority obstacle or challenge. So the options that we have there are supply chain issues, regular refilling and maintenance, technical know-how, intermittent water supply, turbid water, cost, dosing control, monitoring capacity, user acceptability, and vandalism or theft. So I'm seeing lots of responses coming through, which is great. And we will give it just another minute before we have a look at the results. I should also say for the third question, if there are challenges that you're facing that are not on the list, please do put them in the chat so we can see what those other considerations are. And for anyone who's maybe not in a position to be able to do the poll questions right now, these questions will be in the post-webinar feedback survey. So there will be another opportunity to provide your inputs. All right, just 20 more seconds for those of you who are still responding. All right, so I'm going to go ahead and end the poll now. Or maybe Aline will do that for me. So we can have a quick look at the results here. Thank you very much to everybody who has put answers in. Thanks, Aline, for ending the poll there. All right, so we have a lot of water supply professionals responding, which is fantastic. We're so happy to have you on the webinar with us. And then a good mix of people in other roles as well. I hope everybody is able to see these results like I can. So I'm just scrolling down now to look at the second question, where again, we have quite a good spread across all of the different types of activities. So quite a lot of people who are working on implementation, lots of people learning, which makes sense. That is what we're here for. And then some research evaluation work and lots of an almost equivalent, just slightly more people who are providing guidance than who are learning, which is interesting. But that's great. So thank you for those responses. And then to scroll down to the third and final question. I'm just opening it up so I can see this a little better. So we have, I think, regular refilling and maintenance standing out as a very high challenge, very challenging for many respondents, and the cost as well is really standing out. Monitoring capacity, dosing control are also quite prevalent there, and some of the issues that are less of concern for people, there are less people worried about water turbidity. And vandalism or theft, which is great. All right, so thank you very much for participating in that poll and giving us a better sense of who's joined us today. So the next two presentations are going to shift focus to talk about some efforts that are underway to bring together knowledge exchange community and resources to develop and share resources for working through some of these big challenges that we have been thinking about in the poll. So your next two presenters are the leaders of the global community of practice on decentralized chlorine use, Megan Lindmark from COVA and Adam Drolet from PATH. So very pleased that they will share with us a bit about the community of practice, which is currently having a membership of 295 people, hopefully many of you who are here today. So let's go ahead with the presentation. Thank you.
All right. Good morning, good afternoon, good evening to everyone that's joining. It's a pleasure to be here. Thanks very much for joining. My name is Adam Drolet. I'm a senior program officer from PATH, and together with my colleague, Dr. Megan Lindmark from COVA, we'll be talking about the global community practice on decentralized chlorine use. We've heard a lot of great presentations on different ways that chlorine is being used for water treatment and for other purposes in different settings and different contexts. If you're interested in learning more about this, the chlorination space, sharing your experiences, expertise within this area, we have a platform for you, this being the global community practice on decentralized chlorine use. Before diving into what the COP does and its objectives, I'll talk a little bit about both PATH, and then Megan will present on COVA, who are the co-secretariats for this platform. So PATH is a global health nonprofit dedicated to achieving health equity, and with expertise in science, economics, technology, advocacy, and dozens of other specialties, path develops and scales up innovations to the world's most pressing health challenges. In terms of our work in the WASH space, our focus is on WASH in healthcare facilities. And really within that realm, we have three pillars or three objectives that drive our work. The first is working with partners and governments particularly to help strengthen the availability, quality, and sustained operation of WASH services within health systems. The second is about building climate resiliency of WASH services. And there we focus on building that adaptive capacity of both WASH service providers as well as government actors in helping adapt to climate vulnerabilities and risks that are affecting populations and the health system. And then third is digitizing WASH data. So promoting and introducing, fostering the scale up of digital innovations that can help ease the burden and facilitate the use of digital data to drive evidence-based decisions. Now I'll hand it over to Megan to talk a little bit about COVA.
Awesome. Thanks, Adam. Yeah, COVA is a community-centered, data-driven, nonprofit social enterprise. We primarily work across Central America, focused in Nicaragua, Honduras, and El Salvador. And our mission is envisioning a world where all communities have access to safe drinking water. And we do this through a series of safe water solutions focused on our circuit rider model. So our circuit rider model, it consists of a water technician or circuit riders who provide this list of services to 50 communities. We start with kind of a baseline water quality analysis to understand what the problems associated with a rural community drinking water supply is, and then continue to provide ongoing monitoring support, technical assistance, and various capacity building to the community water board, who is directly responsible for the day-to-day operation and management of their drinking water system. And we focus within that circuit rider model on our water treatment technology, which is a low-cost, low-maintenance, easily constructed chlorinator. And so this chlorinator is installed at a tank that then would feed a distribution system for small rural communities up to about 1,000 people. And our circuit riders work with the local water boards to install these chlorinators and then continue to provide capacity support to how to operate and to maintain these systems over time, and then continuous monitoring so that they ensure that we go from water that is accessible to water that is actually safely managed. So now I'll talk to you a little bit about the purpose behind our community of practice. So we aim to be an international consortium of a variety of different organizations who are engaged in the chlorination space. And that can be NGOs, that can be private sector companies, that can be individuals. Anyone who is interested in or focused on advancing chlorine generation or chlorine use technologies. And really we see ourselves as kind of this platform for global learning, networking, and advocacy across this goal. And so what that also includes is kind of trying to engage with and build on this growing global momentum around the importance of elevating existing water supplies to water supplies that are providing safe drinking water. And perhaps most importantly, we seek to kind of platform diverse, inclusive, and equitable voices so that we're fostering open and honest communication and encouraging anyone to share both successes and failings across the chlorination space. So the impact that we hope to have is A, the reduction of the burden of waterborne diseases, and B, the reduction of the burden of hospital-acquired infections, both of which through the delivery of chlorinated water. And so a quick note on our structure: this is a voluntary organization as well as with a voluntary steering committee. And we meet quarterly to talk about a rotating series of topics. So if you're interested in being involved, you can absolutely reach out to any of the three names mentioned here. Previous meetings have included things like technologies for chlorination, service delivery models, emerging evidence, and innovations in this space. If you'd like to see a little bit about our past work, you can access the slides here at this link. And I'll hand it back over to Adam now to share a little bit more about where we're headed.
Great, thanks, Megan. So I know you're all incredibly interested now and want to join and sign up. The two announcements ahead of that. So the first is our next COP meeting webinar will be held on Thursday, December 12th, and focused on chlorination in healthcare facilities, schools, and communities in Latin America. The event will be our inaugural event for Latin America as a region. It will be held in Spanish with live translation in English. Highly recommend you attend if that would work for you. The second announcement is the launch of a technical working group on remote water quality monitoring. If this is an area, again, that affects your work, that you're already involved in, would love to share, would love to learn more, please reach out to those three names on the bottom right. The first meeting will be tentatively held in January of next year. And again, just like the community practice, it's meant to be a platform for sharing evidence, having the discussion amongst practitioners, those that are interested in the topic, and it will be user-driven. There will be a few more objectives and targets that will be announced in that inaugural meeting. So that's our little teaser for you to join if you're interested in learning more. Reach out to Becca, Megan, or myself. Our names and contacts are in the bottom right, and we look forward to your participation. Thanks very much.
Wonderful. Thank you, Megan and Adam. So we are now at our final presentation. We will hear about the Mangrove Water Initiative. So we're going to hear again from Megan and Jeremy, and we're also going to hear from Prof. Amy Pickering from the UC Berkeley Pickering Lab. So without further ado, let's hear it.
Hi, everyone. We're excited to talk to you today about an organization that we've been working on called Mangrove Water. My name is Amy Pickering. I'm faculty at the University of California, Berkeley.
And my name is Jeremy Lowe. I'm a PhD student at the University of California, Berkeley.
And my name is Megan Lindmark. I'm the technical program director at COVA. And as Amy mentioned, we're going to be talking to you today a little bit about mangrove water. And I think first, to set the scene, as you've heard from many presenters today, there's a great deal available of global market for inline chlorination. Over 2 billion people could be served by this type of technology. And this is primarily driven by the fact that fecal contamination is one of the leading causes of unsafely managed drinking water, which could be resolved by chlorination. However, as was pointed out again by other researchers today, there are important considerations for scaling inline chlorination. There are a number of remaining opportunities that need to be resolved in order for this technology to scale and provide all 2.1 billion people with safely managed drinking water. The first is existing infrastructure and technology compatibility. How do we determine what kind of technologies are best compatible with different types of infrastructure? And along with that comes the importance of guidelines for installation, service delivery models, as well as like all of the steps along from installation to actually achieving safely managed drinking water. So Mangrove Water was founded to offer start to finish implementation support for inline chlorination. And we see this as a multi-tiered approach. The first is open source resources for inline chlorination. So building out the knowledge that actually allows implementing organizations to install inline chlorinators. And so this includes some of those key challenges that I mentioned before: guidance on infrastructure compatibility, open source building protocols so that implementers can actually install and construct their own inline chlorinators, as well as protocols for designing operation and maintenance guidance, water quality monitoring, etc. This is all critical to scaling inline chlorination. But along with that goes beyond just the open source resources and actually having implementation support at key stages along the development of an inline chlorination program. So this begins, we believe, at site evaluation, but goes all the way towards monitoring and evaluation. So Mangrove Water hopes to offer implementation support services at every critical step along a project timeline. And finally, we have the third aspect, which is product procurement and installation support. So going beyond just providing guidance on how to do that installation, but actually helping procure the chlorinators themselves. So Mangrove Water believes that these three tiers together can jointly provide improved access to inline chlorination and ultimately scale inline chlorination to offer safely managed drinking water. So if you'd like to know more, if you'd like to get in touch with the three of us, or you would like to continue to hear more about Mangrove Water, or if you'd like to share with us what your organization needs in order to scale up inline chlorination, please scan the QR code and provide your contact information here. Thank you.
Great. All right, so the QR code was left up very briefly in the presentation. So here it is again. If anybody would like to hear more about Mangrove Water, if you would like to share what are the particular resources or things that you would like to see developed, there is the link, there's the QR code again to link to the Google form. And we will also put a link in the chat so that you can click on that if the QR doesn't work for you. Great. So thank you very much to everybody who has already submitted questions, and the panelists have been busy working on answering them with written responses. And now we have some time for more of a discussion. But yes, I encourage you to continue adding questions, and we will try to get to as many of them as we can. So to begin with, I think what I'd like to put to our panelists first are some questions around dosing, because we've had several questions come up about this. And Loic, I might start with you. Because in your presentation, you mentioned very briefly that from the work in Ethiopia, you saw a real step change with dosing where you had free chlorine residual above 1 milligram per liter. But of course, from the WHO, for situations where people are transporting water in containers, the recommendation is at least 0.5 milligrams per liter. So do you want to talk a little bit more about those findings and what are some of the implications?
Yeah, I can. So that 1 milligram per liter was in the storage at household level. So that's, yeah, still much higher than the 0.5. Yeah, it's, I guess the hygiene comes into play here. Because there is so many different recontamination paths happening and not just the water. I think we are not sure why exactly we see that, but like I think that's a question of there is just so much contamination that you need higher dose of chlorine.
Thank you. I might just keep myself unmuted. Thanks, Loic. It's great to have that a bit more information about that result. I think maybe I'll go to Amy next. If you want to jump in on this same question, Amy, about dosing and how you get that balance right.
Hi, everyone. Yeah, I mean, I think dosing is one of the most critical issues with inline chlorination. And I think it takes a lot of kind of like test and monitoring approach based on what the context specific issues are. So in our experience, each system is a little bit different. You have different residence times and different lengths of pipes and distribution systems. And so I think monitoring is really critical to understand what dosing level you need to be dosing at to ensure that safe residual and storage.
Thanks very much, Amy. Yeah, so the point there on the need for monitoring and the need to understand the individual differences of different systems and what works. So I might then go next to Mary Sammy. Mary works with Fundifix providing monitoring support and chlorination operation and maintenance support. And Mary, I wanted to ask if you could say a bit about how you work on dosing in the supplies that you are managing and helping to support, and particularly maybe how you balance these issues of having sufficient chlorine with the user acceptability side, and what people, how it creates issues with taste and perception for users.
Hi everyone. Okay, on our part, to achieve, our FRC is always around 1.0, depending on the type of chlorinator and the type of chlorinator and the source of water. For example, with service water. And for us to achieve an FRC of 1.0, we did a test where that we compared jerry cans of the users. We found that if we set it at, we dosed at 0.5, within 24 hours, there was no chlorine left in the jerry cans. So we decided to set it at 1.0. So by the time the users arrive at their home, the chlorine residue is around maybe 0.5 and 0.8. So if the water stays for like 2 to 3 days, it's safe. So for us to achieve this, we normally do testing within 2 weeks. 2 weeks, like we have attendants at the water points where they test the FRC every 2 days in a week. So they are able to tell us, we are able to compare how the dosage is for us. That has really helped us to maybe maintain the dosing level.
Brilliant. Thanks so much for sharing that, Mary. Great. So maybe we'll move on from dosing and talk about the other hot topic that was asked in several questions, which was about cost. So I might go to Balmukunda first for this question. So several of the comments and questions have raised this concern about the cost of chlorination, and whether that is something that can be borne by the communities. So I know, Bal, that you've got a lot of experience working on chlorination in Nepal, particularly. If you could share a bit of your thinking around the cost issues.
Thank you, Saskia, for the question. Well, obviously, the chlorination setup is something new for Nepal in the present context. The cost is an issue since the chlorination generally was distributed for free by the government of Nepal, and especially during the monsoon days. So a perception was developed in the community that they can collect those things for free, so they don't have any kind of interest over buying those chlorination setup. But now, with the growing changes, with these drying sources, now people are more kind of dependent on stream sources also. So they themselves are more aware that they need to do a proper treatment. And especially in the context where we are working, we have a small, scattered, isolated villages where we have to design and construct these drinking water schemes. So we are more kind of not just relying on spring sources, but we are also dependent on the stream sources. Like, the choice in one of the sites is like, they have to invest some of the cost for chlorination setup. So obviously, yeah, the chlorination in Nepal is quite higher. For example, some of the technology that we have adopted was Pure 100. It was portable chlorinator units or aqua taps. So these are not manufactured in Nepal. So we have to, bring those things or import those things to Nepal. And I remember the COVID period, right? COVID period, the cost just doubled. So it's kind of expensive for the community. Yeah, it's not affordable at the community end. But it doesn't mean that you stop doing things. In the context of Nepal, like, we have more kind of microbial contamination. So chlorination is one of the essential components. So we are now focused on gravity-based dosing unit, which are somehow like, easy to prepare. But again, when you add different components, let's say you want to do some dosing unit there, then it's going to be higher. So we are stick to a lower side, which can be operated manually by the community by reducing lots of human effort, and can also work properly in dosing the chlorination in drinking water schemes. Somehow, yeah, obviously the cost is quite high, but for the cartridge systems, as we are not producing those things in Nepal and we have to import those things from foreign countries. But again, the bleaching powder itself is kind of little less, or it's less expensive compared to other technology. However, it has some, limitations. But we're looking forward to, make changes so that these residues from these bleaching powder could be addressed. So yeah, obviously cost is challenging, but yeah, we are also looking for alternative technology that can be adopted by the community. And nowadays, what I am observing is like, earlier we used to purchase those things from Kathmandu, but now these are available in the far west region also. So, the market is developing. So we are hopeful that, it will be reasonable in coming days, and it's going to be accessible for the community as well.
Thank you so much, Balmukunda. I think that's really helpful to hear your insights. And yeah, as you say very, very clearly, it is a developing space in a lot of ways. So I think there's many things that we will see shifting in the supply chain, and attitudes and the different models for maybe how some of these things are maintained and afforded. I wonder, Donato, if you would like to speak on this issue of costs, thinking maybe more about your work in the Ethiopian context. Sorry, I didn't give you a lot of time there, if you're able to find the unmute.
Yes, could you just repeat the question quick? Sorry.
Yes, so we're just sort of reflecting on these issues of cost and affordability of chlorination services for communities. So we've heard from Bal's work, a lot of his experience in Nepal. I'm wondering if you want to say a bit about the market and the cost issues in Ethiopia.
Yeah, for chlorine, mostly here in Ethiopia, it's used manual chlorination method, and at reservoir. So it's quite ineffective and inefficient in chlorinating, or quite high the risk of underdosing or overdosing. But overdosing is not always the case, because the cost of chlorine is so high. The cost of chlorine in the form of powder, HTH, calcium hypochlorite, is so high, around $9 to $10 per kilogram, that it's very rare even that communities in rural areas are able to afford the cost for disinfecting their water. So most of the time, and even we've seen that during the project with TIAVAC and the Public Health Institute, most of the time they just chlorinate 1 or 2 times per year just for doing a post chlorination for cleaning out the pipe. But what we also see is that the day after they do this post chlorination, again, if there is no more chlorine in water, there is again recontamination happening in the jerrycans used for transport and storage. So yes, just to say that, as many other places in Sub-Saharan Africa, also in Ethiopia, the cost of chlorine is so high that rural communities are not able to afford, and even this is even a burden, even for urban towns or big towns, for having enough free residual chlorine at the top.
Thank you. Okay, yeah. I mean, I think what we're coming up against here is this cost gap issue of what it actually costs to deliver safe water services, and the ability to pay for safe water services, particularly in rural areas and impoverished areas. So I think what it points to is not that chlorination is not important, that water treatment and safe services are not important, because of course we are all here because we think that that people need access to safe water, but perhaps there are some different models and ways of working that we need to be using to make these services available. So Megan Lindmark, I might ask you to speak on this next and share with us some of your work and experience in Central America and how you're dealing with issues of cost and affordability with the COVA model.
Sure, yeah. Thanks, Saskia, for the question. So it's a great question. So the chlorinator itself, and I think I answered this in the Q&A for another person was asking, is usually the chlorinator that we install is usually available for about 150 to 200 USD, depending on the availability of supplies and labor. But more of our model is about, we call it the circuit rider approach. And so this is a technician who visits these communities on a routine basis and provides continual O&M support. So the our cost of our model is not borne instead by the technology, but actually to delivering those services. And we rely heavily on the existence of local community water boards who are kind of the entity responsible for day-to-day O&M at the community level for these chlorinators and for these water systems. And they also levy water tariffs to the community members, which are then used to cover some of the costs of our services. So we don't charge directly for those O&M or the continual support for circuit riders, but instead we sell chlorine tablets to subsidize the services being provided. So all of those trainings, all of that ongoing technical assistance is covered about 50% by chlorine sales to the communities themselves, which is a necessary kind of component to actually maintaining long-term chlorination. So we sell chlorine both to subsidize our model, but also to ensure that there is a high quality access to the correct kind of chlorine necessary for these communities. Happy to elaborate though, Saskia, if there's more I can add there or other questions you have.
Thanks so much, Megan. That's really helpful. I think maybe we will move on from this topic of cost just because we only have 15 minutes left altogether. But yeah, if others want to get in touch with Megan and hear more about that, hear the elaboration, then please do. And join the community of practice as well. So I think what I'd like to address next, there's been a couple questions around, okay, given how much effort it is to do chlorination, why are we focusing on water supply when we also know that there are other routes of exposure to fecal diseases transmitted through food or other pathways? So maybe Amy Pickering and Yoshika, I might address this question to you just to talk a bit about, because I know you've done a lot of research in this area looking at transmission pathways and why are we looking at water as a transmission pathway? Go ahead, Amy.
I'll see if Yoshika wants to go first since she hasn't responded yet.
Sure. I saw there was a question specifically about why should we jump to water treatment solutions? And I also just want to step back and say that safe water is a human right. And so regardless of whether or not there's maybe a pathway that's more dominant, I don't think we want to ignore that fact. But maybe I'll pass it to Amy to talk a little bit more about the relative importance of transmission pathways.
Yeah, certainly. And I think that what we've seen is we've actually done several studies trying to look at all the different exposure pathways that can result in new infections, new enteric pathogen infections among children. So food, water, soil, hands, there's so many different pathways in low resource settings. However, we have found that water continues to be an important pathway for exposure to pathogens for young children. Even children that are breastfeeding, we found in many studies that they still receive water either through formula or through just receiving water outside of breastfeeding. And I did want to point out that we have done a randomized controlled trial in Dhaka, Bangladesh, where we looked at the impact of inline chlorination on child diarrhea prevalence among children under 5 in an urban low resource setting that had intermittent supply and was delivering contaminated water at the point of collection. And one of the reasons we did that trial is because we didn't know if water was going to actually, treating water with chlorine was going to have an impact on child diarrhea, but it did. And we saw a reduction of about 23% in diarrhea prevalence among children receiving chlorinated water, which I think really emphasizes that water continues to be an important exposure pathway for young children. And in that study, also, we purposely dosed under the detection limit after doing a taste test detection study that Yoshika actually led in Dhaka. And so even dosing quite low at the point of collection, we still saw that health benefit.
Fantastic. Thank you, both of you. All right, I think the next question that I would like to address, there's been a question that just came in recently about some of the issues with potential overchlorination. So Marissa, if you can unmute and switch your video on, I might ask you to tell us a bit on this issue about some of the risks with chlorinating, because we've just heard how important it is to be disinfecting drinking water, but then what are some of the risks that we might have to deal with, manage in terms of the risk of overchlorinating, but perhaps also disinfection byproducts, which are often of concern for people?
Yes, thanks. I was actually just about to answer this question in the chat, giving the opportunity here. So indeed, like, of course, we touched on the issue of taste, smell, acceptance, etc. But then we also have the problematic of disinfection byproducts that can form when you do chlorination, especially if you over-chlorinate your systems. And this is a topic currently that is quite understudied in this context. But then at the same time, a little bit the justification of why we still use chlorine is that the burden of disease of these DBPs, disinfection byproducts, it's like not as important as the actual like impact that you have when you disinfect these systems and the impact that you have on people's health. So this outweighs the long-term effect of DBPs. Of course, it's not to say that it's not important. It just, yeah, we cannot afford to not chlorinate the systems, and this has like a huge impact. Yeah, and also currently, like what we observe is recontamination is always a big issue. So for now, like chlorination is an option, and it also helps reducing recontamination issues. Yes, but for sure, DBPs and all this problematic is something that is understudied and needs more attention.
Thanks very much, Marissa. I think what you've just said there about issues with recontamination would maybe touch upon some of the other questions that I've seen coming through in the question box. So I might go next to Mwanzia and Mohammed, if you're still with us on the call. So I'm really keen to hear a bit about the work that you're doing in Kenya and in the Gambia, how you are thinking about chlorination in addition to maybe other program work with CARE and with SHA around safe storage and sort of what happens after the point of collection. If that's something that you could tell us a bit about. So I don't see videos yet, but either Mwanzia or Mohammed, if one of you want to go first.
Hi everyone. Are you able to hear me?
Yes. can hear you. I can't
Uh,
see you, but that's okay. If you want to just keep the video off, that's fine as well.
Yes, yeah, I am. So I am Wansia Kioko, and I work with Care International Kenya. Of course, we are collaborating with the University of California, Berkeley, in piloting and implementing a passive inline chlorination that utilizes the Venturi principle. So I was informed that the team had already presented earlier on before I joined. Yeah, so mine is just to add that one thing that we've learned with the passive inline chlorination, to some extent, it encourages the improvement of water infrastructure, because in our program, in Care Kenya, we are working with a program we call Children Safe Drinking Water Program. And this is a program that has been promoting the use of water purifiers for communities that do not access centralized water systems. In particular, those communities rely on open water sources. So now with the passive inline chlorination system that the UCB has developed and of course implemented by the Care Kenya, we've seen that it encourages improvement of these water infrastructures, just to ensure that we also have centralized water treatment options for that matter. So in regard to, you talked about how now the water will be protected during the transportation, storage, once it has been treated. So one thing that we envision in our implementation plan for the when implementing this device is that the product will be used in community water points, institutions like schools and healthcare facilities. And in such cases, we also plan to have a guide on how, once the water is collected, then how should it be transported and stored. So that, I believe that would be one of the things that we might need to add in our implementation plan, because when these communities connect the water, community water points, then again, there's a risk for post-contamination. But the good thing is that, the good thing is that the device leaves just a significant amount of free chlorine residual, which of course will be helpful in preventing any post-contamination thereafter. So for now, that is what I had to add on that presentation.
Thanks so much. Yeah, thank you, Munzia. And we can see that you've joined us while you're in the car in between sites on your field work at the moment. So we really, really appreciate you taking the time to share your perspective. Thank you. We have just 5 minutes left before we close. I wanted to give Mohammed a chance to jump in on this last question. Mohammed, I don't know if you have anything quick that you want to add, but perhaps we are out of time. I'm not seeing your video. So, all right, maybe we will wrap up the discussion there. I'm sure we could keep talking. There's so much to cover on this topic. But I hope that the webinar today has given you a sense of what work is in progress, some of the work that is in progress, some of the work that is planned on improving efforts to implement decentralized chlorination in many different contexts. We've tried to cover a lot of different settings today, and to hear from a really great range of speakers. So thank you to all of the speakers who've joined us and contributed. As I said, there's a lot more we could discuss. So if you want to continue these conversations, please do join the global community of practice. Get in touch with Becca, Megan, or Adam, so you can be added to the mailing list for that, and join us in December for the next community of practice webinar. And there's also the Rural Water Supply Network Water Quality Action Group, the D group, which Aline has just put a link to in the chat. So please join that as well if you want to continue these conversations with us. And just a reminder, you will receive a post-webinar feedback survey if you have the time and you're able to send us some feedback. That's always very welcome. And I wanted to just give a really big thank you to all of you for joining today, and also to the exceptional Rural Water Supply Network team. Aline, Batima, and Sean, thank you for making this possible. And of course, to the fantastic interpreters who I'm sure we've given quite a challenge. I've tried to speak at a good pace, but thank you so much for all of the interpretation. We really, really appreciate that work. So this is just on the slide now, the upcoming webinars that remain in this series. So there are a few more before the end of the year. Please do register and check these out if these are of interest. And I think with that, I will close, and we are on time, just 2 minutes early. You can have 2 minutes back of your day. Thank you so much, everybody.